that are we actually have 5 speakers that are planned for today, and we want to make sure that we have that opportunity for questions and some good discussion amongst ourselves. My name is Rick Bauer. I'm on the executive committee of PalChase, Palliative Care and Humanitarian Aid Situations and Emergencies. Um, Aaron is also on our executive committee and kind of hiding in the background and helping us with some technical things. And Joan, can you introduce yourself?
Hi, everybody. I'm Joan Marston. I live in South Africa, and I'm on the executive, and together with Rick, we lead on advocacy. So really
So,
good to see
yeah.
you, and I'm looking forward so much to this webinar.
So this is as Joan kind of did the little pitch for our advocacy subcommittee. This is making the case for palliative care and humanitarian aid situations and emergencies. And so we have some great speakers that are going to address this. We've recently have kind of the first very draft of a white paper that we're working on. Will be circulating for your input on on how to make this. We have some great people, some international experts in advocacy, but my goal today is that all of us need to be advocates. And I'm going to age myself, but when I was a very young man, the very famous poster was think globally, act locally. And so, as we look at advocacy, how do we think globally for all of especially our brothers and sisters that are most in desperate need of palliative care, that are in humanitarian situations, refugee situations, war situations? Um, how do we advocate globally but act on a local level? So I'm excited. I'm not going to talk a lot. And I am going to I'm going to do a brief introduction of all of our speakers. Dr. Spyridon Antonios Giannakis is a registrar in family medicine based in Malawi, currently completing his master's in medicine and family medicine at Kamuzu University of Health Sciences in Malawi. He's worked his entire career in Malawi in both the public and private sector since 2013. Dr. Antonio has a strong interest in palliative care and plans to subspecialize in this field in the near future. Dr. Katherine Pettus is well known to many of us as the Senior Advocacy and Partnerships Director for the International Association of Hospice and Palliative Care. She holds a PhD in political theory from Columbia University and a master's degree in health law and policy from the University of San Diego. Welcome, Professor Olena Riga is a doctor of medicine, medical science, MD, professor, pediatrics and neonatology department at the Center of Palliative Medicine, Kharkiv National Medical University, Kharkiv, Ukraine. Arpana Nanda is a research associate at the Center of Public Policy, the Indian Institute of Management in Bangalore. She has prior experience as a psychologist in the psycho-oncology department of Sri Shankara Cancer Hospital and Research Center in Bangalore. Her professional career focuses on mental health and palliative care with a preference for end-of-life care through the lens of public health. She's always exploring different ways to improve the quality of life, care, and death literacy for individuals as well as the broader community. And then Dr. Hiban Osman is the founder of Balsam, the Lebanese Center for Palliative Care, an NGO that provides home-based palliative care, and the founding director of the Palliative and Supportive Care Program at the American University of Beirut Medical Center. She is a member of the WHO EMRO Regional Palliative Care Expert Network and serves on the board of the IAHPC. She's currently an assistant professor of medicine at Harvard Medical School and senior palliative care physician at the Dana-Farber Cancer Institute. So I want to welcome everyone. Again, if you're just joining us, please introduce yourself in the chat area. Each of our speakers is going to speak for just 5 to 7 minutes. I'm going to be the timekeeper and give you like a minute warning. And so I invite Dr. Antonio, if you would like to begin. And Aaron will be advancing the slides. Thank you. If everyone could mute unless you're speaking, that would be wonderful.
Hello, everybody. So my name is Dr. Antonio, as already Father Rick has mentioned, and I'll be giving a brief overview of why palliative care is important in humanitarian situations. Next slide. So just as a brief overview, palliative care is actually essential in humanitarian crises because it helps to alleviate suffering and uphold the dignity of those that are suffering from it. And this is even enshrined in the WHO guidelines, which advocates for integrating palliative care into crisis responses. Yet despite this, it's still not integrated due to various obstacles. And humanitarian organizations should really adopt palliative care approaches to crisis in the crisis setting. And this is where we're going to explain why. Next slide. Next slide. So one of the reasons is it actually improves the health service delivery in these situations. If you consider that palliative care integrating it does not require a huge overhaul of the system as it is right now. It only requires some minor adjustments to place it into there. And therefore it's not as difficult as is often assumed. And even a small change can be very impactful on the interventions when it comes to helping to ease suffering. And when you consider disaster response, there tends to be a save as many as possible. Yet by doing this, we're now excluding those who are dying patients or patients who they are close to dying or they have now something life limiting. And so a save everyone approach is not always going to be in favor of such people. And therefore we need to improve this in order to improve the dignity of those that are suffering. And also this is very important for mental and spiritual well-being. Next slide. In terms of the health workforce, in order for this to happen, we need to train those that are already on the ground in palliative care principles. It doesn't always have to require that we have extra boots on the ground, but ideally there needs to be some palliative care training into those that are already on the ground, as well as have palliative care providers. And the training should cover not just pain management, but also caregiver support and psychosocial counseling. And this is where task shifting is very useful. Even if you'll have palliative care providers, they would still be helping with the emergency response. And in order to make this easier and to reach as many people as possible, task shifting is very helpful, especially those that are local caregivers. Next. So access to essential medicines is often an issue when it comes to these situations because of the the infrastructure is now not as good and has been disrupted. And very often in these areas, previously, before any conflict or any disaster, there tends to be a limitation on controlled substances such as opioids, which is very important in such instances. And therefore, it's crucial that those restrictions have to be lessened, especially in these situations. And as well as having humanitarian responses should ensure a timely access to these medications. We should bear in mind that there's nothing particularly special for palliative care medicines, specific ones, which would cause more of an increase in financial burden, but rather that these are just essential medicines which are commonly prescribed. Next. And in terms of health system financing, the effect of palliative care might not directly cause cost saving. However, when we take into account the moving away from the we have to save everyone approach and rather focus but also focus on those that are dying and those that are suffering as well, you actually in the long term have less mental suffering and less long-term effects, and therefore it ends up being more cost effective in that way. And this means that efficient resource use can help in the same way free up supplies for those that are non-palliative care patients. And this is why including palliative care can optimize the healthcare spending in such crisis settings. Next. So in conclusion, palliative care is actually a moral, social, and humanitarian obligation. It actually brings humanitarian organizations back to what they originally were supposed to be, which is the relief from suffering. And integrating palliative care will actually enhance this effectiveness of disaster responses. And this means this all goes to show that a true humanitarian response has to include efforts to relieve and alleviate suffering. And in the next few presentations, we'll see in more detail such aspects that show that palliative care is so important in this respect. Thank you very much.
And thank you, Dr. Antonio, and bonus points for being on time and making my life lovely. Thank you. Thank you so much. And our next speaker is Dr. Katherine Pettus. Katherine, make sure you unmute.
Sorry about that. I'm just going to put my slides in presentation mode. All right, so you can see my slides, and thank you, Rick.
Yes.
Thank you.
Catherine, I'm still sharing. Do you want me to stop sharing?
Oh no, okay. Am I sharing?
No, I've advanced for you.
No, I need to do what I've done, but you're not seeing my notes or anything, right?
No.
Okay, great. Sorry.
But we can't see your slides, so if you want to try and reshare yours, if that's easier.
Yeah. No, Erin, she would like you to advance the slides.
Perfect.
Yeah, no, I just had to do it so I could read the notes. Sorry for the misunderstanding. Joan, did you hear that I said please send Hiba a link?
Yes, I have done so.
Super, thanks very much. Okay, so we ready to go? Rick?
Yes.
Over to you.
Okay, thank you. So hello, everybody again, and thank you for the introduction, Rick, and everybody who joined for being here. Pal Chase is a member of the International Association for Hospice and Palliative Care, And we try to collaborate as much as possible on advocacy. So I'm honored to speak to you briefly today about a few fragments of the international legal framework. It's also called the normative framework governing palliative care provision in humanitarian emergencies. So every recommendation in Dr. Antonio's presentation just now, which said that this is what government should do, your governments have all agreed to those things, meaning that they're part of this normative framework I'm about to describe, which is why advocacy is so important. Next slide, please, Erin. So first of all, what is a global normative framework? Well, as opposed to a national, regional, or local framework, it's a set of aspirational rules, standards, and laws, some of which are binding for many different practices like trade, labor, etc., but for our purposes, health policy. So there's a global framework for health policy, which we're talking about today. And importantly, these are rules and laws that all governments in the UN have agreed to. They have debated them, they've argued over every comma, every word, and they've agreed to these things that I'm going to talk about in a minute. So it's called normative because compliance is ideally the norm or normal behavior of a government. So it's ideally, palliative care is normally part of what is provided in humanitarian situations. That is what the law says. States have agreed that it should be normal for governments to provide essential medicines during emergency, and so there are rules about it. But the challenge, of course, is enforcement. The important thing to remember is that NGOs such as PalChase and IAHPC cannot enforce, but with other organizations and academia, we can hold governments accountable for the fact that since they include palliative care in the normative framework, it must mean something. As civil society, we are also part of the global normative framework. And I don't have time to go into that, but the UN includes civil society organizations such as ourselves in their legal framework. And legal norms are being violated all the time, as we know, and we can call out those violations through advocacy. Next slide, please, Erin. So the international normative framework specifies the duties and obligations of all parties to the law, in this case, concerning humanitarian access to armed conflict situations or natural disasters, and those include both humanitarian actors and governments. So there are rules about how they can access combatants and non-combatants. Human rights treaties and humanitarian conventions identify the conditions under which actors can access those who may be in need of assistance and protection, as well as the conditions that must obtain in a country to guarantee the highest attainable standard of health through the, next slide, please. And these laws and customs are based on the principles identified in the UN Charter. They're also principles of palliative care practice and advocacy. You can see that dignity, freedom, and non-discrimination are the principles we apply both to practice and to advocacy. And in other words, if the international normative framework is based on these principles, then the people who live within that framework are worthy of care that aligns with those principles, such as palliative care. Next slide, please, Erin. A key document in this framework is the Universal Declaration of Human Rights, whose logic is based on the concept of equal sovereign states inhabited by equal human beings who have equal human rights. And just because a state is in conflict or war or experiencing a disaster does not mean that citizens forfeit those rights or governments can put aside their obligations to protect them. The goal is always development of individual and collective capabilities, which are supported by states' obligations to protect the right to health. Next slide, please, Erin. So the right to the highest attainable standard of health in international laws, including in emergencies, is stipulated in the International Covenant for Economic, Social, and Cultural Rights, which was approved by all countries in 1966. In 2000, so almost 40 years later, the Committee on Economic and Social Rights, which reviews the covenant, and it updates it, so to speak, stipulates that states shall have an obligation in all circumstances to maintain a functioning healthcare system, provide essential primary healthcare and essential medicines, and design and implement public health strategies. Now, primary healthcare includes palliative care now, thanks to advocacy a lot of us have done, and essential medicines now contain essential palliative care medicines, including morphine and other essential opioids, mostly generics. So they must have a strategy under international law to allow those services and medicines to be provided. And that's because palliative care is now part of the normative framework, which it was not for a long time. So it's hard for that to get into people's heads when they're doing relief work or they're planning health systems. That's why we have to really keep pushing for advocacy. So palliative care is part of the right to health, and that's from General Comment 14, which I just mentioned, which was approved in 2000, I should say, by the Human Rights Council. And it says that states are under the obligation to respect the right to health, by inter alia refraining from denying or limiting equal access for all persons to palliative health services. It's unfortunately, they put it in the negative like that, but what that means is that they must provide palliative health services and not refuse it to anyone. And that priority must be given to the most vulnerable or marginalized groups of the population who, as we know, have palliative care needs. The next slide, please, Erin. So the Geneva Conventions and protocols stipulate that all parties to an armed conflict must ensure that adequate medical care is provided as far as practicable and with the least possible delay to the wounded and sick shall be collected and cared for. So obviously that means they need palliative care. Next slide, please. And the UN General Assembly resolution approved in 1991, which I thought was very interesting. That means it was approved by, again, all your governments, stipulates that each state has the responsibility to take care of its victims, and that can also be interpreted as conferring an obligation to provide palliative care. If the state can't provide it, it should receive assistance from other states. And then last but not least, as Dr. Spyridon mentioned in terms of the framework, there's the palliative care resolution approved again by all member states, all governments in 2014 about developing palliative care policies to support the strengthening of health systems. This needs to be done before humanitarian crises, and if it's in place already, can alleviate much of the suffering that would otherwise go untreated. And I can't stress enough that this is an obligation of member states to ensure a functioning health system during times of conflict, and that the obligation to aid victims is a multinational one. It's not just something nations get to choose. So that's what makes attacks on health workers so egregious, as we've seen both in Ukraine and in Gaza, because they're violations of the Geneva Conventions to have a functioning health system. And finally, there is a list of these guidelines and declarations, which is to do with providing palliative care and essential palliative care in emergencies, which I won't read, but there's plenty of them. And you can get these from the slides when they're shared. So thank you, and here's a brief recap. International normative frameworks support the provision of palliative care in emergencies, including essential palliative care medicines. If you don't take away anything else from that, take this. And the advocacy and education of policymakers, other civil society organizations, and humanitarian organizations is essential to promote the standards that already exist. And the picture on the right of this slide is the top part of the joint constituency statement that the IAHPC gave at the WHO Executive Board meeting with all our co-sponsors, which are other civil society organizations, but not necessarily palliative care organizations. We have to reach out to lots of other organizations to make this happen. And Dr. Hibble will talk about this later, I believe. So here's a list of my references with links if you want to check any of them out. And thank you, Rick.
Thank you so much, Katherine. Great, great. And I now welcome Professor Olena from the Ukraine.
Okay. Thank you very much, dear colleagues. Good evening, good afternoon, good morning. Dear colleagues, it's a great pleasure to be with you. And first of all, I would like to say many, many thanks for all people who support my country and my people. And of course, we talk about status quo in our regional clinic center of rehabilitation and palliative care for children in Kharkiv. Is a frontline zone from Ukraine. And next slide, please. The challenges that the war posted are quite different for us. And of course, the war divided our lives into before and after. And no war changed our life, everyday life. It changed our reaction, fear, anxiety, rage, hopelessness, helplessness, sadness. Of course, all these emotions present, and every day we took negative information. For example, today there was destroyed children's hospital in Odessa, especially children's hospital who provide palliative care for kids. And of course, our reaction of our nation was negative for aggressor. Next slide, please. Palliative care services divided, of course, on the two zones, occupied area and our controlled area. You can see that twins, it's my patients who was in the first day of life, who were in the first day of life on the occupied territory. First of all, the mother has written us about no approach to the food, to the anti-seizure drugs, and then all connection disappear. We don't know what happens with this family. Of course, the palliative care provided depends on staff. Many refugees was in our country, and more than 8 million people are now replaced to the Europe and other countries. Next slide, please. Then I would like to present some strategies in our regional hospital, regional center of palliative care. And of course, as for me, is some stage during these 3 years war. When the bombing was about 60 per day or more than 60 per day, all people were in underground, in subway. And of course, please, next slide, we replaced our residents to the basement. Next slide, please. Okay, you can see sorry, return, please. To the you can see the environment when our residents, our mothers with palliative care, our staff, and of course our patients have leaflets about nuclear war, of course, because it was very high risk at this period of. Then, please, we lost our staff not only by refugees. Next slide, please. Our head of department comes to the army. Erin, please, next slide. You can see the left picture. It's our head, Roman Marabyan. And of course, the other picture is our pediatricians, men who come to the war. Next slide, please. We have a support from other countries and some of children who need in palliative care and some family we replaced to the Germany. Now they are from March 22 and we thank every country who got our patients and support them. And of course, you know, some many programs from many countries. Continue, please. Next slide. We start to give some period of our working was so-called empty or died because no work in any our center, but sometimes we start provided services for family who lives not far from our centers. Yeah, it's a safety first of all. And these services was as outpatient. Next slide. Now, from May of this year, from 2024, we provide mobile home-based palliative care team. And now 54 family are under our services. But as for us, it's very important. This family no citizen from Kharkiv city. They live in a rural area. And that's why, you know, the rural area have a loss approach for services. That's why we provide the services there. Okay, thank you. Next slide. I would like to show you, next slide, please. That there is increase of kids who need in palliative care due to loss of siblings. And of course, now in our calculation, it's rise up in 15% of all patients in palliative care, unfortunately, due to this influence of war. Next slide, please. Then, of course, humanitarian crisis in our country continue. And of course, there is a risk of separation. The parents may think that we may die every day. That's why the parents write on babies and toddlers' body number of telephone, name, surname, because this risk present, and of course it's in frontline zone as our one. Then next slide, please. Bombing during night. Next slides, please, Erin. Bombing during night, of course, leads to the risk of loss of children and families, and that's why there is a so-called rule as three wall in room protect from death. That's why you can see the really how our kids sleeping. Next slide. We know in occupied territory there is abuse, not only on the women and also on the children from Russian soldier is a fact, and about 93,000 complaints to the prosecutor's office regarding rape, including young children. Continue, please. And of course, some humanitarian, it's a NASA picture about blackout. Of course, blackout influence in the working of our healthcare system. Yeah, not only family about mechanical ventilation, about other support that depends on the electricity. That's why it's also crisis situation and influence in providing of our services. Continue, please. And not only total blackout, you know about some climate catastrophe. For example, Aksakzam Kakhovka hydroelectric power plant was destroyed by the Russians. And of course, it's also influence not only kill for our people, its influence in our climate zone. Please, next. The main thing is such situation is just too close to each other, of course. In this sense, it's a paradigm of palliative care, yeah? For support, it's archer. There is one way for our surviving now in this our situation. We are grateful for the international community. I am personally grateful for John for being there and for support us, okay? And thank you very much for everyone. And now I would like to tell you we finished some analysis and some research about intersectional corporation social providers and medical providers in frontline zone. And in future, I may also to share with you. Thank you very much.
Thank you so much, Professor Elena. And I just struck that so many times we're in our offices and we're just thinking, oh my gosh, you know, the barriers to providing palliative care seem overwhelming. Well, you have just thrown that argument out the door, because if Ukraine can do this, we can all do this. And so thank you for your witness that we can do palliative care even in the midst of horrible situations. Our next presenter is Aparna Nanda. The floor is yours. Thank you.
Hello, everyone. So I will talk about palliative care in context of the climate crisis. Next slide, please. Yeah. So we all know that we are in midst of a climate crisis. The intensity and frequency of the natural disasters has increased, and it's going to keep increasing in the future. These climate crisis leads to significant loss of life, destruction of property, roads, houses, and displacement of the surviving population in turn increases migration health risks. And mental health challenges. A lot of mental health challenges come up. PTSD, depression. There are several studies also with hospice and nursing home population where it was observed that following a severe hurricane, the mortality rate of the population increased threefold. So that's a huge damage. And plus, because of the poverty driven by climate change, the UN has stated that there are around 26 million people who are pushed into poverty. Next slide, please. So here are some factors that impact palliative care. So like many other resources in the world, man-made or natural, not everyone gets equal share. So because this reflects in climate crisis as well. So with climate crisis and natural disasters, the marginalized populations of the society get it worse. They get affected worse. Like, let's say, for example, there's a cyclone. So whether, even if you're in the same city, whether you live in a concrete house or you live in a hut, it makes a lot of difference. And the LMIC are again like affected worse. Climate change also, worsens the food insecurity that is already prevalent in the world. Many patients depend on their friends, family, neighbors, and community in general for support. And because of the climate change driven poverty, the social cohesiveness and the social support has reduced a lot. Another thing that was observed was when evacuation takes place, usually people do get evacuated, but the medical supplies, medicines, the medical equipments, they remain damaged. And in a in a post-disaster scenario, because there aren't enough equipments and supplies, the quality of care that can be palliative care that can be given to patients is like, it's very bad. Next slide, please. Yeah. So some of the challenges while providing palliative care during disasters, I'm sorry, I saw the cat, so I got distracted. So locating patients becomes a substantial challenge because of infrastructure damages and broken roads. A lot of things like healthcare workers find it difficult to reach the patients, and it becomes difficult for the patients to get evacuated. There's a lot of lack of phone connectivity, and the movement of medicines and medical supplies, even that becomes limited because of the broken roads. And again, there aren't many healthcare workers that are trained for emergency situations. So the ones that are trained, they become overwhelmed. And and during these kind of disasters, the aid that the government provides, it's usually done through centralized units. So it is very difficult for a seriously ill person to go to these centers, wait in lines, and take their part of the aid. And we have another issue that health systems also prioritize resources for people who have better survival rate. We saw this in COVID as well. So even there is a disadvantage for people who need palliative care. Next slide, please. Yeah. So to counter these challenges, we need robust infrastructure, which includes policies and mechanisms at various levels. Regional level, state level, and national level. And cross-skill training is important, where humanitarian health responders are educated with the palliative care aspects, and the humanitarian health responders are, sorry, and the palliative care responders are, educated with the humanitarian aspects. Places like hospitals must have a tested emergency plan which evacuates people and the medical supplies, and makes sure that the roles and responsibilities are clearly designated so that there is no confusion, because time is very crucial in these matters. And then we have volunteers. Volunteers volunteers are very handy in these situations. We saw this even in the Kerala floods that I will soon be talking about. And so volunteers form their own shelter points. So the reach of volunteers to the patients and people in need is far larger. And the burden on healthcare workers to reach those patients and people in need is reduced. These kind of planning and having mechanisms in place can reduce a lot of loss of life, and also minimize the quality of care providing, the damage to the quality of care provided. Next slide, please. Okay, so how Kerala dealt with palliative care during the floods. So when we are talking about palliative care in India, Kerala gives a lot of hope. So some of the key components of Kerala model in context of palliative care includes community participation. So a lot of volunteers are trained. It's very community based also. So you have your friends helping you, your neighbors helping you. And because of the participation of volunteers, it becomes a very home-based approach. So the benefits of this is, patients don't need to travel to clinics. That saves them a bit of money as well. There is no unnecessary hospital admissions. It reduces burden on hospitals. And also the needs, the medical needs, emotional needs, psychosocial needs are given to the patients in the comfort of their own home, where they will be much more comfortable. Another important thing in Kerala was collaboration between various bodies. So there was government and NGO collaboration, there was government support and policy framework. One example of this collaboration would be Kerala State Disaster Management Authority, Pallium India, and IAPC worked together. So because these big bodies were working together, like the effectiveness of the measures that were implemented were multifold. It was, and like, next slide, please. Yeah, I'll say. So when it comes to collaboration, so there were multidisciplinary teams. So it was like a diverse pool of skills were available to deal with the different aspects and the different needs of different people. There were social workers, there were palliative care workers, there were ASHA workers who were conducting these health assessments and, reaching rural areas, reaching remote areas. There have been times where, they will go to this specific place and the last stretch they will have to walk 3 kilometers, 4 kilometers. They did that. And they even provided medical support and psychosocial assistance, but also physical aids like wheelchairs and hearing aids. Pallium India also conducted a session on palliative care for the panchayat members. So panchayat members are, let's say, village head and village council members. So this became by sensitizing them about palliative care, it became easy to dispense information. So again, like it was like a lot of people knew what is to be done in the time of emergency. Also, there were planned and monitoring surveillance of disease and medical issues, again at different levels. So what this did was it minimized the number of deaths, and it also helped contain any outbreak of disaster related diseases, let's say for cholera or something because of contaminated water. So it wasn't just the direct effects of disasters that were taken care of, but even the indirect and secondary things that get affected, even those were taken care of. Again, coming to the volunteers, they had and have a very critical role. So one of the things that happened in Kerala was because the palliative care was like the infrastructure was already established properly, the volunteers knew what is to be done. So there was like, when a lot of people know what needs to be done and are trained, there is less confusion, there is less fear. So all of a sudden, if you don't have a particular resource, you're still not scared. Eventually they are going to get it. There is less burden on healthcare workers. There is less dependence on bureaucracy, because when officials get involved and bureaucracy gets involved, it takes a lot of time to get things done. But with volunteers, that time was saved a lot. So in conclusion, I would like to say that, we know that climate related disasters are going to increase. And with palliative care and the patient's needs, the continuity of care is very important and we cannot afford the disruption. So in that way, I feel that, it's very important that when we talk about palliative care, we have to talk about the effect it has from a climate change perspective as well, because global warming is not going to go away. And thank you.
Thank you so much, Aparna. I know we're just a few minutes over, so I want to quickly... It's okay. I want to quickly invite Dr. Hiban Osman for your presentation, and just jump right in, Dr. Osman.
Absolutely. Thank you. And so I'm Hiba Osman. I'm a palliative care physician from Lebanon, and I do work in Lebanon, Palestine, but I'm actually physically in Boston right now. I'm also on faculty at Harvard Medical School. As you can see, I'm in clinic. And I just wanted to share my experience. So since we're over time, I will be quick. want to say that for most of the people in this webinar, you are working locally and trying to make local change, and that's wonderful. And it might be overwhelming when you hear from people like Aparma and Olena and the wonderful work that they've been able to do and what they've been able to achieve. It's it can feel that their achievements are not tenable in different circumstances. And I think what I would like to share with you is my experience doing advocacy globally with the support of IAHPC and Katherine, who spoke to you earlier, and how this impacts advocacy at the local level and what you can accomplish at the local level. So I was fortunate enough to join the IAHPC delegation to the World Health Organization Executive Board meeting earlier this month. I learned a lot, so I'm going to share some basics that you may or may not already know, that the WHO has 2 executive board meetings a year in which decisions are made about what the organization wants to prioritize. The decisions are made by member states. So as an external actor, as an NGO, we do not have any decision-making power, but we have a lot of advocacy power. And so what we do is we can give statements, but also a lot of where we can create movement is by doing advocacy work with our member states to push things forward, because ultimately the decision making is theirs. And I found this very interesting because I worked for a long time in advocacy at the national level in Lebanon, and we were able to make a wonderful change. But when you look at it from the global perspective, ministries of health and governments and WHO country offices are not going to make major change if the decisions are not coming from above. So Katherine spoke earlier about palliative care getting integrated into primary health care, or palliative care medications being integrated into essential medicines. If those are decisions that are made on the global level, it gives you much more power to advocate at the national level, because these decisions, as Katherine said, are already made. So in this group, we're talking about integrating palliative care into humanitarian settings and health emergencies. If the decisions are made at the global level, then it becomes much easier for us to advocate at the national level for integration. So this is a picture of myself and Dr. Sharon, who was the other member of our delegation, and we were meeting with Dr. Q, who's at WHO. He's the contact person for palliative care. If you can move to the next slide. Yes, so this is just to illustrate the directionality or the bidirectionality of advocacy work. So in the picture, you can see the 3 members of the Lebanese delegation. In the left lower corner is somebody from the consulate in Geneva. The gentleman is a psychiatrist who's part of the Lebanon delegation, and pictured giving her statement is also somebody from the Ministry of Health in Lebanon. But ahead of the meeting, Katherine was coaching me to reach out, share our statements with them, and encourage them to integrate palliative care into their statements, specifically the one on health emergencies in humanitarian settings. And as you can see here, the Lebanese delegation talked about palliative care being crucial to the future of health and quality of life and dignity of patients. So pushing and putting palliative care on their radar makes a difference in terms of what they push and the meeting at the global level. And if decisions are made at the global level to integrate palliative care into health emergencies, then we locally can push for that to happen. So it's working on multiple fronts. I do want to say that at the IAHPC, and I'm a board member at the IAHPC, and that's how come I was a member of the delegation, but you can join as individuals, national associations can join for free. And a big part of what we do is helping train and support people in their advocacy work locally. And next slide, please. As you can see from the experiences shared here, palliative care in humanitarian emergencies can look very different in different places. But by working with each other and by networking with people, so at the WHO meeting, I got to meet a lot of people doing this work. You learn from them, and you share ideas, you learn from them, and that can help you be a better advocate at the local level. So when we're talking advocacy, it's important to figure out who the decision makers are. So at the WHO, it's the member states. Within your country, it's certain people at the Ministry of Health. So you need to figure out who they are. Building coalitions is important. So you're not advocating as an individual, you're advocating with other organizations, as you saw from the statement that we gave at WHO Executive Board meeting. We were in coalition with multiple other organizations, which makes it a more powerful and credible statement. And then you lobby, you network, you meet, you talk to people, you push things forward, and then you follow up. So it's not just one meeting, it's not just one telephone call. You need to follow up. Thank them when things move forward, check in when things are not moving forward. I think that's it. Is there another slide? How am I doing on time? Right. Oh, okay. And this is just another plug for IAHPC. I strongly encourage you to consider joining, especially for national associations, because we have a wealth of experience of people who have had made very strong movements forward at the national level. Thank you.
Great, great, great. And thank you to all of our speakers. This was just incredible from all over the world, and the wealth and for me, the passion that you all have is just incredible. And so I want to just point out that Katherine and others, we've been putting in, if you'd like to join the IAHPC, Katherine put in that membership section. If you'd like to join us in PalChase, this webinar, through karma and grace, that kind of came together because we need more people. We are a very, very loose organization, but we're filled with passion. And in our advocacy and our desire to provide palliative care to often those people that the world has forgotten, whether it's war or natural disasters. So want to thank everyone. I want to open up, if we have any questions, or Joan, I've been doing a lot of talking. I'm going to turn this over, kind of my co-chair.
Thank you, Rick. There have been a couple of comments and questions about the climate change crises, and specifically around Kerala. And Dr. Shani has made a couple of comments about the volunteer training, how the community came together. And I wondered if Dr. Shani would like to speak to those comments and just unmute yourself.
Yeah, sorry about the lighting and all that. I wasn't prepared that you would ask. Okay. Yeah. I just wanted to say that in Kerala, Aparna Nanda has given a fairly brief and comprehensive picture of that. Thank you for that. The nurse's role in providing home-based care and the volunteers, of course, is very highly commendable. And every panchayat kind of appoints a nurse. They hold the nurse as, for the palliative care leadership. And it's wonderfully done. And I believe home care and home-based palliative care is the way forward, even geriatric, especially in low resource settings or where there is access is limited. Building up infrastructure would be another thing that is at the secondary and tertiary level. But I would very strongly, especially for Nanda, I would love to connect with her. Since we are in the same country and the city. I would say strengthening community-based nursing would be the way forward for countries which are struggling with, scaling up services, just like the Kerala model. Yeah.
Thanks so much, Dr. Shani. And having been to Kerala and seen it in practice, I totally agree that actually we have to get it down to the community level. And I think that what really has impressed me is the fact that despite the challenges which Professor Alina and Aparna spoke about in these real acute crises, and we recognize these are only two crises that we have had examples of, but we know there's so much more going on in Gaza, in Sudan, across the world, and climate crises just about everywhere. And it's so encouraging to see that what can be done, despite the fact that there is this horror going on around you. And Dr. Islam has pointed out he's from South Asia, where they get a lot of climate crises. There's floods, there's cyclones, there's all kinds of crises there. And migration, it causes migration. And so one crisis builds on the other. You have a climate crisis, people migrate. You have conflict situation, people migrate. And on top of the conflict situation, you might get a climate crisis as well. And so it's not just having one crisis, it's having multiple crises. And he was asking what can be done at community level. And I'm not sure, Aparna, whether you would like to speak to that or whether anyone else would like to address that.
I'm sorry, I was typing for Dr. Shani. So can you repeat what you were saying?
Yes, it's Dr. Islam who lives in South Asia and in his area experiences a lot of climate crises. And with that comes migration from the country to the city and vice versa as well. And he was really asking what could be done at community level in those situations. And I think that you addressed that in your presentation, as well as Dr. Shani, who has now spoken about the use of volunteers and how palliative care was part of the positive response to the floods. I don't know if you'd like to address anything else on that.
So, yeah, I'm not sure how much information I can give that can be used, but I'll just try to say what my understanding of the situation is. So, one of the problems that comes with, the difficulty in replicating the Kerala model in other states in India itself is the cultural differences. So because over here it's like a few kilometers away, again, you are like a different set of culture is there. And the way people behave or the things that people pay attention to is different. So that makes it difficult. And for any community-based or volunteer programs, I feel we have to really look into the specific set of people and have tailored interventions. Not just interventions, the way you educate the people, the way you educate the, let's say, the village panchayat members itself. It would be, you have to be very, the approach should be very culturally nuanced. That is how we'll get to the non-medical, the non-professional people to help. So in my this thing, what I would like to do is, and this is something we even talk about in palliative care and especially in advanced care planning, that the best way or the best time to start is when you are healthy. So when there is no disaster, when things are going fine, that is when you start training. So you will have a lot of space and a lot of time to do a lot of trial and error to see what works and what does not work. So by the time that a disaster actually strikes, people are already prepared. They know what is to be done. So yeah, that would be it.
Thank you so much, Aparna. I think those were very valid points that you made. Catherine, you
Catherine.
wanted to say something.
I just had a thought, and I'm not an expert on this particular issue, of course, but one of the things I do know is that when people flee, whether it's a humanitarian crisis, climate crisis, war, they often don't take all their documents with them. Health centers are destroyed, like we know, and so medical records are lost. And maybe the doctors here can talk more about whether this is feasible, but I know that some countries have electronic health records that would be, or what's more portable, if you have to leave actual paper documents behind. Is that a possibility? If you can, as you said, before the disaster strikes, put in a system where people's health records are not something they, obviously if they leave them behind, but they can be retrieved.
Dr. Antonio?
Yes, this is just an observation that I noticed when I visited earlier in the war, when I visited Uzhhorod in Ukraine. And what the family medicine department was doing there was they were actively addressing the internally displaced peoples coming from Eastern Ukraine. And because many of them had paper documents in terms of their health records, they were changing that into, as best they could, into electronic records. And with that, they could now be in the system and they could go and retrieve their chronic medication from like the city center reserve or something like that. Maybe Dr. Prof. Elena can expand on whether this is unique to that particular area or if that's a national thing.
Okay, we have, of course, we have electronic system nowadays in our medical health, but there is a contract between patient and medical history, and especially some people, old age people, who have approach to the internet resource, maybe not have these electronic records. It's a big problem, especially people who has mental retardation. And for example, our person who replacement may loss of other documents, but of course some data is present in our medical health, of course these records, and we during for last 3 years we provide palliative care and financial by government. That's why very easy to be in list of stakeholder and taking of these services. It's important, very important to have electronic variants, but my example about occupied territory, we may not call in this humanitarian crisis, we may call by simple telephone for our patients because Russians destroy our provider of telephone, and that's why sometimes it's impossible. Sometimes it's impossible, different situation. Thank you.
Thank you. And I think also I was just sitting back here, the opportunity for advocacy is with each of us. And it's for me, those of you that know me, it's like every time, Rick opens his mouth, how is he going to get palliative care into the conversation? Because this is so important, not only for our colleagues in the medical profession that still have misunderstandings of what palliative and hospice care is, but also in our communities, in your social networking posts. Are you putting palliative care out there to get communities talking about palliative care? I know I'm looking at Joan, this is what revolutionized HIV care in the early years of Africa, is we educated communities about palliative care, that comprehensive care, not for death, but for life. And so every opportunity, how can you work palliative care, whether you're speaking with your colleagues in the clinic or with community members, that we're constantly putting this up there? Because I think one of the lessons learned, and Katherine, I know you said this, is there has to be at least a base of palliative care, hopefully before the humanitarian disaster crisis, global, the environmental crisis, the humanitarian crisis, the war, the refugee crisis, that we need to ensure, as with what Katherine said, that our local areas, our governments are advocating for the integration of palliative care into all clinical services. I'm looking at our time and it's at 11:12, and I'm supposed to now turn this over to Erin for any final comments. I can't thank you all enough for coming together and for your passion. Erin.
Thank you, everyone. Sorry, we have a bit of background noise here, but it's really great to see you all. We were a group of about 37 at some points, on and off. Thank you, Dr. Hiba, for your time, Dr. Katherine, Dr. Alina, Aparna, and I think our initial Dr. Antonio may have dropped off. Oh no, he's right there. Thank you so much, everyone, again for the session. We run our webinars at Palchase every quarter. So we would love to welcome you back. One of the best ways to get connected and have a personal connection, of course, it's often virtual, but is to join a working group. So Joan mentioned that we have 4 working groups at Palchase that meet regularly. If you are interested in education, if you are interested in research, communication, or advocacy, of course, which was highlighted today, you're more than welcome to join us. Please do keep in touch, and hopefully we'll see you at our next webinar, which will be happening in April. We'll share some more information shortly. Thanks again, everyone, and please do take care of yourself in all your work. Please be safe, and we are stronger together. So yeah, thanks so much. Have a good evening wherever you are.
Thank you, everyone, and thank you especially the speakers. And Alina, just keep safe.
Bye-bye.
Bye-bye, everyone.
Bye. Thank you.
Bye.
Thank you, Rick.